Hey, this is Chapter 16 of your ward in History, caring for the woman experiencing complications during the postpartal period. So, postpartum hemorrhage. This is defined as any blood loss greater than 500 mils after vaginal birth or 1,000 mils after a C-section. It can also be a hematocrit decrease from 10% from pre-birth levels to post-birth levels. It's really important that you measure actual blood loss. So you can kind of watch the pads, the placenta basin, any suction canisters, and you can weigh those pads. 1 mil equals 1 gram. So there is early stage of hemorrhage and late stage of hemorrhage. An early hemorrhage occurs within the first 24 hours after birth, and a late hemorrhage occurs more than the 24 hours, but less than 6 weeks postpartum. So, uterine atony. This is when the uterus myometrium fails to contract and retract after birth. So what happens is when there's a lack of that contraction, there's going to be non-compression of the arteries and veins that's at that placental implantation site. So what's going to happen is the uterus is going to fill up with blood and clots, and that can cause hemorrhage. Any genital tract trauma, especially during that second stage of labor, there could be some soft tissue trauma, and a woman can bleed from that. After the delivery, the physician will examine the placenta and make sure that all the placenta is there. However, if the woman retains any placental tissues, that can cause some bleeding. And then thrombin. This is where there'll be problems with the maternal coagulation. So that can be like thrombocytopenia, low fibrinogen levels, or from the HELP syndrome. Late postpartum hemorrhage. It's not very common, but it usually happens within the first couple weeks. The most common cause is from the retained placenta that we just talked about. And hypovolemic shock. If there is more than 1,000 mLs of blood loss, then hypovolemic shock can occur. We talked about shock in the last unit. If you see restlessness, anxiety, kind of that cool clammy skin, tachypnea, tachycardia, and then that decreased blood pressure, hypotension, that can be an indication that shock is impending. So collaborative management. Make sure that you are doing frontal checks for uterine atony. If the fundus is boggy, you're going to want to massage it, see if it confirms up. You're going to want to assess INO, assess vitals. You want to give fluids. So, hematoma. This is a collection of blood. It can be anywhere. Some of the signs and symptoms that you'll see is pain, pressure, and how you can treat it. If the patient has like a vulvar hematoma, you'll have the patient lay on their side and bear down If the hematoma is pretty small, like 3 to 5 centimeters, usually the physician will order ice. Sitz baths will be done after 12 hours after having the ice. And if it's larger than 5 centimeters, the physician might have to drain it. So next we're going to talk about the different kinds of infections. This can be endometritis, urinary tract infection, mastitis, so endometritis, this is the most common site of infection is in the uterine endometrium. The patient's going to have a high fever. They're going to have that really foul smelling lochia. And what puts the woman at risk for developing endometriosis is when this after delivery is when she's having her first baby, a delivery with forceps, a C-section, or any intrauterine pressure devices. Mastitis, that usually develops after the flow of milk has been established. Staph is the common culprit. And the infection, what happens is edema will occur and kind of block that ductal system. And so the woman will have fever, malaise, breast tenderness. It's treated with antibiotics, heat or cold, and the woman will need to empty her breast every 2 to 4 hours. Breastfeeding is okay, but if the woman is has cracked nipples and really sore nipples, she may not want to breastfeed. Just do like a breast pump to kind of give her nipples that break from baby feeding on it. So collaborative management, again, antibiotics, encourage protein and vitamin C, like sitz baths, warm compresses, therapeutic touch, NSAIDs can be helpful in managing infections. Make sure you're teaching infection prevention, like wiping front to back, washing their hands after they go to the bathroom, using that, if they've had a vaginal delivery, using that squeeze bottle, drinking extra fluids. So thrombosis, or thrombophlebitis. So this is thrombophlebitis is any inflammation of the veins, and what happens is a thrombosis can develop, and there'll be a blood clot. Some of the risk factors is like varicose veins, venous stasis. So some of the signs and symptoms, the patient might complain of like leg pain, calf pain, tenderness. You might see swelling. If you do a calf circumference, one might be larger than the other. They might have kind of a it could be like a bluish color, or it could be a deep red and be hot. So diagnostics, they can do Doppler, They can do a D-dimer. So really you're going to want to try to prevent. So using like support hose, increased fluid intake, to manage it. Make sure that the patient's pain is under control. You want to avoid massage. But what can happen with DVTs is that it can turn into a pulmonary embolism, and that's where the blood clot will travel to the lungs, and the patient will have chest pain, they'll have difficulty breathing, they'll be really diaphoretic, anxious, feel like impending doom's coming up. So really you would want to stabilize that patient, give them oxygen, they might need CPR. If they stop breathing, put in an IV, make sure that fluids are going. The patient's going to need some heparin, morphine. So postpartum complications. So mom can develop postpartum blues, which is pretty normal. So they can have it usually up to the first couple weeks. But really, if it goes on longer than that, mom can develop postpartum depression, where they have a depressed mood, they don't feel like doing the things they like to do. And really, you're going to want to make sure that you assess every woman at their follow-up appointments or when you're making your OB calls, making sure that she's not having postpartum depression. But if she is, make sure that that you are reassuring her. Don't make sure she doesn't feel like she's crazy, and that it happens to other women and that's normal. Postpartum psychosis, this usually occurs within the first 8 weeks after childbirth, and it's different from postpartum depression because this mom will end up being in like a manic state where they are suicidal, having hallucinations, delusions, confusion. They'll be real disorientated, and this requires hospitalization. So again, just making sure that you're using your therapeutic communication, and that you're really reassuring her, because some women, they don't like how they feel. Imagine feeling depressed and not being able to control it. They may feel ashamed, but really reassure them, because imagine mom is exhausted, she's stressed out, she's overwhelmed. Make sure that her partner is really giving her good support. So the populations that are at higher risk for developing postpartum depression and psychosis are victims of abuse, undocumented immigrants, and those who have limited access to care.